vital that you can give.
Can you all hear each other still?
No, I think I see the critical care lounge thing and music.
Yeah, but you guys can still talk. I just want to, we can still talk here, but I just want to make sure that we go live for the people who are waiting.
Oh, I see.
Welcome to the Critical Care Lounge. My name is Haney Malamat, and to my right, to that right, is Adam Green. What's up, Adam?
Hey guys. Thanks for coming back and joining us. How you doing?
Well, I'm doing great, trying to survive this storm. We had tornado warnings, which usually you just brush off, but they were like, get to shelter now. So it got really serious really quick. So how about you? Did you get any of those warnings?
You know, I'll tell you one thing. Rain makes me want to lounge and talk about ultrasound.
Oh, there it is.
Almost like
There
it was
is.
planned. Almost like it was planned.
Well, thank you for joining everyone at home. Thank you for your patience. We're getting started 20 minutes late, but we always like to say a live host is better than no host. So thanks for your patience. And why don't we just go ahead and introduce our panel for tonight, and then we'll go over what the logistics will be. What do you say, Adam?
Sounds good. So I think you guys, for those of you who are new here, thank you for coming. The general theme is laid back, real world, gray zone topics in critical care. So today we have two guests. We have Dr. Singh, a former fellow of Cooper, who's now at Piedmont Columbus, taking names and owning the place. And he's an ultrasound master. So I'm thrilled to have him here. And then right next to him is Dr. Wolf, one of our recent graduates and new attendings at Cooper. So both are outstanding, far superior to me. So I can't wait to sit back and learn from them.
And I'll be monitoring the chat. So if you have any questions or concerns, just go ahead and hit us up in the chat. Whenever there's a break or a lull, I'll try to address them, or we'll save them for the Q&A session at the very end. But thank you both for being here. We greatly appreciate it. And what do you say we do some cases? How's that sound?
Sounds great.
All right, great. So let's go ahead. We're going to get the cases up here. And when you need me to advance, just advance. But these are cases that you provide with us. And I don't know about you, Adam, but I didn't look at any of the cases, so I don't know what's coming. I like the element of surprise. All right, here we go. So this first case, whose case is this?
I think it's my case, yeah.
All right, Jiki, do you want to give us a little stem about what's going on?
Sure. So this was a young guy. I think he was in his late 20s or early 30s who presented with signs and symptoms consistent with shock. Hypotensive, tachycardic, lactic acidosis, did not have any prior history whatsoever. And his clinical examination also was in line with shock. He had cold extremities. Like I said, he was hypotensive. He was fluid resuscitated in the ER. That did not help him much. He had bilateral crepitations in his lungs. He was a little short of breath. And all his labs, his troponin was elevated, did not have any ST elevation MI, lactic acidosis, like I mentioned earlier. So he was started on pressors and was moved urgently to the ICU. And as soon as he was in the ICU, as part of the initial assessment, a point of care ultrasound was done. And this is the first of the two videos that we have. So obviously this is the parasternal long axis view, and then we have. Do you want me to describe the video, Adam and Haney, or?
But so I think we probably have a variety of learners. So maybe
Okay.
Dr. Wolf can just kind of go through her thought process and what she's looking for and
Yeah.
what she's taking from this, and then.
Yeah, this is definitely not an ultrasound that you would expect in a 30-year-old otherwise known medical problem, right? So right off the bat, this screams, something is wrong, something is abnormal. And just looking at the size of the heart, it is like a big balloon to me. So clearly abnormal. The first one that we see right here is a subxiphoid view. And both the left and the right side of the hearts are very ballooned up, big size, not moving too well. And if you look at the apex of the left ventricle, just for the beginner there, this is a subxiphoid view. Your most anterior, which is the part that's closest to the liver, is going to be your right ventricle. And then next to it is your left ventricle. And then the two atriums are on the bottom of the screen there. So not much pericardial effusions, maybe some mild pericardial effusions, but definitely not moving well, big heart, and possible some thrombus on the apex of the LV there.
Great. So what we'll do now is we'll go to the next clip. And, this as Adam said, there may be some people on here that are beginners. We want to emphasize the fact that never commit yourself on one view. There's a multiplicity of views when you do point of care ultrasound for a reason. You want to confirm your findings if you find something abnormal in multiple views to make sure it's not artifact. And then the second is that every view gives you additional information, if nothing else, just to confirm what you previously saw. So here's another view.
And that is a really good point, Dr. Malamet. Definitely, try to get as many view as possible. One view is no view, in my point of view.
That's a lot of views.
So again, here you see parasternal long axis view. You see the LV right in the middle of the screen there. And then on top of that, the right ventricle, the aortic outflow tract, the aorta itself, aortic root looks normal size just by eyeballing it. But we have big LA, big LV, and that echogenicity at the apex of the LV is still there. So that makes my suspicion for LV thrombus stronger now that I saw it in two different cuts. But yeah, this is a very interesting case, especially in a 30-year-old, very dilated cardiomyopathy picture like this. So I guess if this happens in the United States, I would say viral induced of some sort of infection would be the most common. Um,
Yes, I think that's what the etiology was in this case, and obviously, when in the clinical setting that he came in, the shock, the lactic acidosis, the overall cold and clammy extremities with this kind of an echo, the diagnosis of cardiogenic shock. I wish I had the VTI and the cardiac output images as well. But those were pretty consistent with a low stroke volume, low output overall state. Uh, now, do you want us to talk about a little bit about VTI, Adam and
Yeah,
Haney? And
what I'm
yeah,
thinking here is this case is obvious, right? I think most people can look at that LV and say it's not working
sure.
the way it's supposed to. Maybe you can talk a little bit about simple ways to evaluate the LV. I don't know, do you look at the mitral valve? What view do you look at? Other ways to look at for not the not so obvious cases. And then yeah, if you want to talk about VTI or other aspects, that would be great. That'd be great.
Mhm. Okay. So, for the beginners, whenever you're looking at the LV there, like Dr. Wolf said, do not commit to yourself to one view. Uh, you're not going to have this kind of a case all the time, even in cases of cardiogenic shock. So you really do want to look at the LV in different views. The parasternal view, when I was a fellow, Haney used to famously say that either you're going to have good parasternal views or you're going to have a good subcostal view, right? And that still holds true, especially in your vented, patients with ARDS or with any kind of lung involvement. So you do want to start with your parasternal view. At least I start with my parasternal views, and the parasternal long view, which this clip is, it will give you a good idea of how the left ventricle is doing, especially at the level of the base, which is close to the mitral valve, and uh, the mid area of the left ventricle, which includes the papillary muscles. The apex sometimes, not the parasternal long axis, is not the best view to be able to look at the apex, but it will give you a good idea of what your left ventricle is doing. And like Adam mentioned earlier, the mitral valve. Now, in this case, if you see, the mitral valve is there's a good enough distance between the mitral valve and its opening
Frozen connection.
idea.
I think JK is a little frozen. I think I'll finish his point and then he can correct me if I'm wrong. But I think what he's saying is you see how that anterior leaflet there is not coming up and hitting that septum, that anterior septum, or I should say the interventricular septum, and that would be indicative of poor systolic function. He can correct me if that's not what he's going to say, but I mean, would everyone agree that that's kind of what that indicates?
Yeah, I would definitely agree. And some people might even put an M mode in, to get that E-point septal separation. To be quite honest, the more I do it, I don't do the EPSS as religiously anymore. I find that eyeballing the movement of the LV or, the movement of the mitral valve itself usually are sufficient. What are your thoughts? Do you guys do the EPSS religiously?
There we go. So in terms of the EPSS, GK, we saw that you froze up and then we let you back in. Do you want to finish your thought? Unika was taking over and talking a little bit about E-point septal separation, EPSS. So one of the things we should probably do is talk about normal values, and then the other thing we should do, as I see you freezing up again. Are you frozen? Frozen. but then we can answer it at what normal values that they are. So I'll answer, just since I'm talking, I'd say that it's something I use more of a gestalt. It's not something I put my hat on. What I find the older I get and the more ultrasounds I look at is that there's nothing definitive. Really, there's nothing definitive in medicine overall. What you try to do is collect as much data as you can, and the stuff that overlaps the most is what sticks, and the stuff that's extraneous you throw out. But that's my thought on EPSS and whether or not you use it. GK or Adam, what are your thoughts on that?
Yeah, I think the only reason I was mentioning is because it was so clear in this case. But as you guys said, I personally have not been using it in terms of the values. You're just eyeballing, like Yannicka mentioned. But to come back to the left ventricle, I think after this, the parasternal short axis, which is pretty much just flipping it 90 degrees from this point, and then trying to assess the left ventricle at different levels, at the level of the base, at the level of the papillary muscles, and going and tilting the probe further to be able to look at the apex is, at least when it comes to the parasternal views, it will give you a lot of good information if you can get good views in terms of what the left ventricle is doing. Also, with regards to the interventricular septum and the interaction or the dependency of the right ventricle and the left ventricle. So I do begin with these views and then go to the four-chamber apical view, which will probably give us more information. So when it comes to the left ventricle itself, parasternal long view is the first view, at least what I look at, and then parasternal short axis views at 3 different levels, which will give me a rough idea. And by that time, I should know what the left ventricle is doing before even when I'm trying to look at the 4-chamber apical view. And like we say, in this case, we are looking at not only a LV, which is not doing much, but also we're looking at some LV thrombus. And all this is good if you have good parasternal long and parasternal short axis views. Yes.
Great. So looks like, is there anything else to extract from this case? Because we spent a little bit of time, I got some really good learning points out of it. Any other takeaways that we should know about this case or some key learning points?
Well, in this case, because of this diagnosis and the use of POCUS, this patient was transferred to a tertiary center, and he ended up getting a heart transplant. So I think the point here would be early recognition and diagnosis, because if you see the timeline, this was early morning, 02:57. So generally an echo would not be done. An echo is not going to be done for someone like him in the middle of the night in a community hospital, or maybe many a times in a bigger hospital as well. So when there is early diagnoses, then things will move forward, especially in a young patient. So I do feel that this led to early detection of a DCM with LV thrombus, and in the initiation of anticoagulation, and then the initiation of a transfer to a higher center. So again, if you have a clinical question in regards to why my patient is in shock, then POCUS pretty much is standard of care to be able to diagnose the etiology of shock early.
Well said. Yannicka, any other points that you want to make on this case?
No, I think we covered all the highlights.
That's great. Yeah. So as you said, 2:57 in the morning, he had the echo done, which is a vast improvement. I think you're right, even in academic centers. And then I think you told us offline that 8:30 in the morning he got his heart transplant. So because of you, within 6 hours, this guy got a full heart transplant. GK, that's pretty amazing. Great job. And his screen is frozen. He can't even appreciate the.
It's also amazing. It's also amazing. You notice there was no Doppler, no color. There was no fancy echo moves that I think intimidates probably most people who are starting doing echoes. That was easy to do at bedside, and probably anyone can learn those skills relatively quickly.
Yeah, I think that's well said. We'll move on to the next case, but the point I want to make is I never want to scare anyone off when we're talking about point of care ultrasound or echo. This is not these fancy things, I gotta say that we teach at Cooper, I think that they're probably like 15% of what you need to manage your patients. If you have a good, solid understanding, take a basic ultrasound course, you could make a huge impact, a huge delta on your patients. And then the worst case scenario, I think it's still a good case scenario, is you pick up the cardiologist and say, listen, I don't know exactly what's wrong, but this doesn't look good and my patient's very sick. So come on inside. And once you get that rapport with them, they'll call the sonographer in for you rather than like, I don't know, I have a patient in shock. Can you come do an ultrasound? So hopefully that translates well. Look, we want you to learn everything, but don't feel scared away if you only get to the point of just knowing basic stuff.
Yeah, that's a great point. That's a great point. Just one thing if I can add is it's the not so great or not so fancy things which actually, in my experience, make a big impact. It's that putting that probe, getting a good view, and actually doing POCUS, which really makes a huge impact. I'm sure that fancy stuff like that we all do makes somewhat of an impact as well. But doing POCUS and encouraging POCUS really makes an impact when you are able to get those simple views and make early diagnoses in young people like this patient.
All right. Phenomenal. Now, I kind of screwed up here, and I apologize. So I'm going to give it the choice to you guys. I put another case by GK next. Do you want to mix it up and skip over to Yanika's case, or do you want to stay with GK's case and do Yanika's case third? It's your call, whatever you guys want.
Anything.
Let's just keep going then. And this time we'll be a little quick about it, so we get through all the cases if we can. All right.
Okay. So this is he's 65 year old male who was admitted for failure to thrive, the medicine floor. He had a PEA, cardiac arrest. That's how the ICU got involved, and he was ACLS, followed, resuscitated, and then moved to the ICU. And any post ROSC patient should have a POCUS. I think that's pretty much standard everywhere now. And this was the post ROSC after the patient was lined up and stabilized on pressors, intubated, and this was the first view. And and like we said, there were no parasternal views available because we were just not able to get any of them. And this was a subcostal view, 4-chamber, looking at both the ventricles and both the atriums. Yannika, you want to take it from here?
Yeah. Another good one here. So again, subxiphoid view or subcostal view, you see the 4 chambers, and quickly taking a look at the surrounding of the heart. I don't see any big pericardial effusion. One thing that attracts my eyes here is the right atrium. There is something bouncing up and down in that right atrium. I'm not quite sure what it is yet, but it doesn't seem normal. Now, granted, right, we need to get more views because there just could be an artifact or something else, but that certainly attracts my eyes. And the RV is also bigger compared to the left, although it could be because of the cut, but definitely abnormals.
Great. Should we go on to see more views?
Absolutely.
All right.
Okay. So this, and everything that Yannika said, basically, looking at that first view and the clinical context in mind, the patient did receive TPA. Now, the challenge with this case was that this patient had a low platelet count. It was being evaluated on the medicine floor, but at this point he did have thrombocytopenia, and I think it was less than 50. So the amount of TPA which was given was around 20. Bolus was 25 milligrams, and then an infusion was initiated. The point was to try to keep the TPA as low as possible to prevent any kind of a bleed. So this is when 25 milligrams IV of TPA was given, and serial point of care ultrasounds were done with the hope to achieve or to see if we are able to relieve the RV or the obstructive shock, to relieve the RV pressures, and then at that point, possibly the TPA could be stopped. So this is after 25 milligrams of IV TPA. And then, Yannick, are you going to take over from there?
Can I ask you a
Yeah,
question?
so
Please.
How do you know it's not just endocarditis?
Yeah, so this was a great point. Again, the clinical context. What we were trying to, if this was just uh, a point of care ultrasound, which was done on a patient who was not post cardiac arrest, we would definitely not be giving TPA. But what we even in that clinical context, what we were trying to look at is to see if independently of the tricuspid, if this structure was moving. Meaning that if was there enough distance between the tricuspid valve and the thrombus for us to be confident that this is not infective endocarditis. And earlier in the first video, it was not very clear to us, but some other views that we were able to get, which are not here, we could see a big difference between the tricuspid valve movement and the thrombus. So we felt in the clinical context, with the views that we had, we were confident that this was a thrombus. And on top of that, we had a DVT study, which was pretty significant. On the right side, the common femoral was obstructed, and we were able to visualize a thrombus there as well. So, keeping the entire clinical situation in mind, we decided to give 25 milligrams of IV TPA. Again, the dose is debatable whether that was the right dose or not, but that was our clinical rationale to use 25 TPA.
no, that's great, GK. And as you said, taking into context everything else. And I love that you did the DPT study too, because that certainly can push you more towards considering PE as your top diagnosis. Um, yeah. In some cases, you can put color Doppler on it and see, usually valves with endocarditis, vegetation, if you put color Doppler on it, you'll see some regurgitation, some evidence of regurgitations with color Doppler. But in a big RV like this, the annulus are spread apart, dilated, you probably would see some regurgitation too. So I think the DPT study was the one that clinched the diagnosis, not necessarily this subxiphoid view.
Great. Were there any more clips to show for this case?
There's one more. I think that's the same one. That's the first one. There should be one more.
Was it this one?
No, that's
the
the first one.
The second one.
If not, I can describe.
Yeah, if you don't have it, let's just talk it out.
Yeah. So at the third view basically showed that the RV was much smaller, RA was much smaller than the LV and the LA, and then there was no clot, or the clot pretty much disappeared, and that went in line with the clinical shock state as well, with the patient being weaned off vasopressors, and the point was that with the last echo image, where we really couldn't find any thrombus in the right atrium, and the RV was much smaller with less obstruction over the LV, we stopped IV infusion. So overall, with the help of point of care ultrasound, the patient got less TPA that the patient would have received otherwise. With serial point of care ultrasound clips, we were able to safely stop the TPA at a dose which was much less than what it would have been if we had not used it. So that was the point or the takeaway in this case, where doing serial point of care ultrasound in a case where we clearly see RV obstruction, we see a thrombus or a clot in transit, and then titrating the TPA with looking at obstructive physiology of the RV.
That's phenomenal. And what dose of TPA were you infusing at?
So 25, and then we were giving 25 over 1 hour. And at 30 minutes of the IV 25, we stopped it. So the patient ended up receiving 25 plus 12.5. So
over
around
1 hour.
Yeah, yeah. It was at 30 minutes we stopped it because that's
30
when we
minutes,
got the
gotcha.
last clip.
Sure.
Yeah, yeah,
Fantastic. Great. Adam, any other comments for this case?
No, that was great. That was really good.
What a super cool case that was. All right, let's keep it moving.
All right. So this one was coming from a 32, 34-year-old gentleman, history of IV drug use. His overall presentation was just very vague, fatigue, tiredness, nausea, vomiting, not feeling well, and he was hypotensive. So initially he was being presumed septic, shock, and was treated with antibiotic. And these are the four, I guess, three views total. And if you want to move on to the next one, it's going to give you an individual bigger versions of this clips. So this is your parasternal long axis.
All right, so why don't we do this, GK? Do you want to just run through how when you see a clip or
Sure.
when you're scanning, just talk us through how you systematically do it? Because I think what people will get is the rhythm that you go into
Sure.
when you do this.
Yeah. So clearly, this first view is a parasternal long. You're looking at the left ventricle. You're looking at the mitral valve. You're looking at the left atrium. You're looking at the aortic valve, the outflow, and then this is a good screening for the right ventricle as well in terms of what the RV outflow tract is doing. So in this view, you could say that the left ventricle might be slightly depressed, but you need more views, to be honest, to be able to give that assessment. But what is striking is that if you closely look at the aortic outflow tract, there's a echogenic structure which is in the anterior part of the aortic outflow tract. Now, is that an artifact or is that something real? That more views would make a or more views would tell us better in that sense. But clearly, when if I see this in the clinical context that Yannicka just described, I would definitely want more views, especially in terms of the 4-chamber, 5-chamber aortic valve. Also looking at the right ventricle, because with this limited view, I don't see the RV that well either, and I use this as a good screening tool for the right ventricle anyways. So yeah, worried after looking at this for a number of reasons, and then looking forward to getting more views would be my takeaway with this.
Perfect. Yeah, I've always been taught ignore the right ventricle unless it jumps out at you in that view, right? So let's move ahead. Tell us about this. What do you see?
Yes. So looks like a four chamber apical. We're looking at the left ventricle. Now the left ventricle on this is on the left side. So for the beginners, not to get confused, it's just the way it was taken, and then the way the arrow was, or the pointer was. The left ventricle in this view, it at least at the level of the mitral valve at the base, I do see it coming in nicely. There's still a question regarding the apex. I don't see the apex moving that well as compared to the base. But what is definitely striking is that if you look at the right ventricle and if you look at the tricuspid valve, you will see a echogenic structure which is moving, I would say, in sync with the tricuspid valve. And I think it's a great it's great that we had that PE and this video as well, because I do see when we have thrombus, and like Yannicka initially said, you do need more clinical context with a thrombus versus endocarditis. But if you can see that the movement is synchronous when it comes to this echogenic structure as compared to the previous one. So my suspicion for infective endocarditis is very high in the clinical context described and looking at this view. More color here would also help in terms of looking at the tricuspid regurgitation or the level of DR in this case. But definitely infective endocarditis is top of my differential in this after looking at this clip. Yeah.
Perfect. You want to move on to the next clip?
Mhm. So again, it's a four-chamber view. I think the view for now. Tell me, Yanika, was this the same exact view but just a clearer picture or a clearer clip in this case?
Yes, this
Okay.
is a clear picture with one thing that we haven't mentioned is
Mhm.
some irregular finding on the pericardium itself, like around the
Okay.
heart itself.
Mhm.
There's something that's not quite normal,
Mhm.
um, and you know, it, it's not as obvious when you took a look at the first few of the personal lung for sure,
Mhm.
but when we pay attention more on this particular clip, if you looked at more to the side of the left ventricle, you're gonna find a little bit of echogenic area and then echolucent area that just doesn't usually belong there.
It almost looks like the hyperlucent pericardium is disrupted. Is that am I looking at the right spot?
Correct. So,
Absolutely, yeah.
so right next to the apex of the ventricle, on the left ventricle,
So
there's
tell us,
the
spill the beans. Tell us what it
one.
is.
Yeah, so this guy ended up having a pericardial abscess. So there are some abscess collection around the pericardium itself, that's sort of like squishing on the left side of the heart.
Mhm.
So in addition to the infective endocarditis on the tricuspid valve that's obvious in this picture, he also had abscess around the heart itself, or around the
And
pericardial.
aortic valve involvement, correct?
Correct. But on this picture, it's not obvious. I can remember if I included the one with more obvious um, picture of the aortic endocarditis or vegetation.
Now, can I ask a question, Yanika, regarding
Yeah.
this? So, when you first saw this, were you suspecting a pericardial abscess, or you thought that could this be a fusion? And let me try to get some better views to see if this is a pleural effusion versus pericardial effusion. Did that thought come in? Because obviously, pericardial abscess is so uncommon, right? So,
Very
did you get some views to try to differentiate between pleural versus pericardial?
Here,
Yeah, so this case is actually courtesy of Dr. Green.
yeah, I was going to
I'm
say I
gonna
was
Well,
attending, so I
let
can take.
him.
I'll tell you what I saw. What I saw was left and right sided endocarditis, and we got the official echo, which then revealed the pericardial abscess. And so we said, "Wow, that's cool. Let's go find it." But no, I missed it on the first look. And and the case itself was rather amazing. He had evidence of CNS septic emboli. He had pulmonary septic emboli. He was in renal failure, probably also embolic, and 3 or 4 pressure shock at one point. And I don't know what his end result was, but he certainly was extubated and left the ICU. So
He's good. I took care of him, and he did great.
yeah.
That's awesome. That's a really awesome case. Yeah.
So anyway, shall we
Well-
should we get to some questions, or is there any other points that you think we should highlight?
Any other clips on this that I know there were a couple more left in the set.
Oh, this one. So this one is actually I included because it's very interesting. Um, if you look at again the left ventricle, there's some echogenicity within the left ventricle itself that just doesn't look normal, right? Is this thrombus? Is it not thrombus? Is it spontaneous contrast, spontaneous echo contrast? Um, it's just the swirling of blood that's happening on the apex. And this is because the apex of the heart is not moving quite well. So this is your harbinger of thrombus formation, especially in the LV. So if you see this, strongly consider full anticoagulation in your patient.
This is what the cardiologists call smoke. You know, you're seeing like
Smoke,
smoke in the
correct.
LV, or if you see it in the left atrial appendage, then that would be suggestive it's kind of pre-clot. There's stasis and more density. That's great. Anything else in this? All right, great. Well, let's go to the Q&A, and let me just check out the chat. Now's the time. I've been sort of priming everyone in the group if they have any questions that they want to ask about the cases that we saw or anything in general when it comes to echo. I certainly have a couple questions, but I want to turn it to the audience. So let me just make sure. Adam, do you have any questions in the interim? Anything that you want to ask?
I think my question always is, let's say you're new to the ultrasound and you show up in the ICU and you're ready to go. Where do you start? I mean, what's the first view? Where do if you try to shoot for everything, you shoot for the stars, you probably are going to get confused and lost. So what's your recommendation to the newbie as to how to pick up, where to go?
GK, do you want to take this first? If you're not frozen.
Yannicka, you want to take it?
Oh, sure. So what I would say is get your hands on the echo probe. That's your first battle, right? Just bring the echo machine everywhere at bedside. And that's usually like the limiting step, rate limiting step. Because if the echo is not on bedside, you're gonna less likely to use the echo. So just get a probe and then start with your 4 basic view: your parasternal long axis, your parasternal short axis, your apical view, subcostal view, and don't get discouraged if you don't get all 4, because unfortunately, in reality, in the ICU, we don't have the perfect patient with the perfect body habitus, the perfect positioning. So just be patient and keep doing it. If you don't get the view, just keep at it. One day you'll get it.
Yeah, and I'll add to that, whenever I'm scanning with somebody and I see that they're spending a lot of time on the parasternal long axis view, I say it's okay to go on to the next view and then come back to it later, because sometimes you'll find that the next 3 views confirm it and you didn't have to go back to it. And typically when we're doing these studies, they're in patients who are very unstable. You need quick answers. The nurse is wanting to get in there to get their drips hooked up, and you're kind of in the way. So just keep moving. And I find oftentimes the next view is like, oh, I didn't even need the first view in the same place. Still go on and always complete the exam is my advice. But yeah, if you get hung up on the first or second view, just say, park it, let's come back and do it again. It's okay to go out of sequence.
Yeah, GK, am I cheating if I start with the subcostal, because I kind of get an understanding of where the heart is and I know where to go from there? Is that okay?
No, I don't think that's cheating at all, because many of especially in your COVID patients, that's the only view that you're going to get. So I don't think it's cheating. I think everyone has a way to do it. I don't think one way is better than the other. I think at the end, if you are trying your best to get multiple views, especially if you're taking intervention, and what I would say is that sometimes when you have the echo probe, and you're trying to get answers, there's a lot of pressure on you. There's a lot of people looking at it, especially when you're starting early on. A lot of people will want you to give them a diagnosis. A lot of people will want you, and then what ends up happening is that you inside will want to give an answer, and then and that's very common. That's more common than we think it is. So it's important to know that any intervention that you're making based off POCUS, it has to be solid. Your information has to be solid and should not be pressurized into making. It's always good to say, what I'm looking at, I don't know what I'm looking at. I don't think based on this I should be making an intervention. So it's always important to know that that you, by making an intervention, you can lead to patient harm as well. I think if the beginners know that it can go both ways. You can catch a great diagnosis and make a big impact in the patient's life. But at the same time, if you are not sure, it's okay to say, I'm not sure. I don't feel an intervention is needed because I'm not very sure about what I'm looking at. So I think it's important to know that aspect of POCUS as well.
Yeah, I mean, that's a great point, and I always emphasize that to the new learners, because they, like you said, they want to say something. Radiologists, even the most trained radiologists, they'll hedge all the time. If the study's not good, the information's not good. It's okay. It's okay to say clinical correlation suggested. No, in all seriousness, you shouldn't be afraid to say that. It's better to say, I don't know, look for something else, than to make the wrong call. And that happens, unfortunately, when I get QAs from other institutions. So that's great advice.
Yeah, I think I've, and maybe I'm just not an expert, but I find that 95% I suspect a diagnosis based on the clinical story, the labs, the imaging before I even touch the probe. And that the probe, generally speaking, just confirms what I was already thinking. And maybe I just need to spend more time with the two of you to pick up my skills. But tell me that's not totally inaccurate.
No, it's absolutely not inaccurate. I think coming back to what Yannick had mentioned earlier, the more you do, the more you practice, the better you will get. I think it's point of care ultrasound is something that you can get very good at it very quickly, but it's about getting the right answers for the questions you have, which is important. And the more you do, the better you get in small nuances in terms of how to do the four views. That is very easy to start off with. But how to answer questions which are relevant for patient care, that's where it takes more time and more experience and more learning. Yeah.
That's great. All right. Any final thoughts, Yannicka and GK? Any thoughts or any other things that you want to add before we let everyone go? We don't want to go too late tonight.
No, yeah, just keep on scanning.
All right. Keep on scanning. I love it. There's a T-shirt in there somewhere. Well, I want to say thank you to both of you for taking the time out. Adam, any thoughts before you and I wrap up?
No, I thought that was great, and I think we've got a theme for future sessions that I think we should keep looking at images and keep doing this. I liked it a lot.
Great.
Thanks for having us.
Thanks
Thank you.
for being on.
Thank you so much.
Adam, that was pretty cool. That's number 2 under our belts of the Critical Care Lounge. I really like this format of bringing people on and picking their brains and just hearing how they think, because it's one thing to just say, here's an interesting case, here's the answer, but it's really cool to see their gears turning and coming up with differentials.
Totally agree. I absolutely agree. Well said.
Awesome. Well, we are going to keep up this cadence and do the lounge every 2 weeks. So put on your calendars. We're going to be coming back in 2 weeks. Now, just in full disclosure, our schedules had already been out when we decided to go live with this. So it might be a Tuesday, a Wednesday, or a Thursday, depending on what we can line up. But aim for 2 weeks. So the week of the 14th, expect some notification that we're going to be going. We'll get it to you beforehand, of course. But that week, just plan on the Critical Care Lounge coming back. And as we put in our schedule requests, then we're going to have a very definitive time, date, and calendar for you. So we've had great response on YouTube. The last video, Adam, is going crazy with Dr. Dellinger and Dr. Shuba, and I anticipate this video, once it's on YouTube for a while, will be the same thing, because those two big brains we just had on were just phenomenal.
Although I think this video makes me a liar, because last time I promised ECMO, and we did not deliver ECMO. But
you didn't have to point that out, but you're an honest man, and I appreciate you for that. So yeah, we were supposed to do ECMO.
There's a reason, is because we have the perfect guests who were busy, and we just thought rather than pushing the topic, we should wait for them. And so
that's right.
Hopefully it's in 2 weeks if the schedule aligns. If not, at some point we will do ECMO.
Patience, isn't that what they say? There's something that someone said once about patience, and we're playing the patience game. We're playing it perfectly well for this ECMO because these two guests are going to be phenomenal. So just stay tuned. Maybe next time. All right, Adam. Well, it's always good to hang out with you here at the lounge, and we will keep everyone updated. And hopefully no tornadoes will be coming through your neighborhood, Adam, and no one watching at home. But I'm wishing you everyone well. My name is Haney Malamat, coming to you from Critical Care Lounge. Adam, you want to send us off?
Yes. Thanks, everyone, for watching. And until next time, keep scanning.
Take care.
Take care.